Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. This episode, I'm delighted to have Dr. Abiola Fasina-Ayoola, who's a Nigerian emergency physician who trained in the US and is now spearheading the introduction of emergency medicine in Nigeria. She explains what her and her colleagues at the National Postgraduate Medical College of Nigeria are doing in terms of driving academic emergency medicine and the founding of a residency program in a country where none of this previously existed just a few years ago, and what that looks like 6 years later. We speak about her experience as a woman in a country notorious for gender inequity, especially in recent current affairs. We also touch on the withdrawal of USAID and PEPFAR. And then we end off with some general wisdom about how to speak to politicians and how to get things done. As always, everything said represents our own personal opinion and does not represent any organizations that we represent. Without any further preamble, welcome to the show, Abiola. Would you mind starting us off by just introducing yourself and giving us a brief background of your professional career so far?
Sure. So my name is Dr Fasina-Ayoola. I'm an emergency physician. I'm US trained. I went to Mount Sinai School of Medicine and did my residency there as well, and then worked for a while as a consultant before I went back to the University of Pennsylvania. I completed a 2-year point of care ultrasound fellowship. Then I worked again, but I was always doing global health. So I was always back and forth through Africa. And in 2019, I had the opportunity to move back to Nigeria. Initially, I actually came back as a research physician with a vaccine trial unit. It was a good way to come home, and I got some really good research skills through that. And then a year after I moved back home, I transitioned out of that role, decided to stay in Nigeria and pivot to emergency care and development. It's always been my dream. Emergency medicine, all the times I was coming home, doesn't really exist here. And I was finally in Nigeria and just decided I would just give it a run and see if I could make something out of it while I was here. And that's how I ended up in Nigeria. And since then, I've been running crazy like a headless chicken.
So you obviously were born and raised in Nigeria and then went across to the US for undergrad. Is that correct?
Well, actually, I was raised in Nigeria. My parents are both Nigerian. I grew up in Lagos. And then I went to the States for university. So I went in my late teens. And I was there for 19 years, but I was always coming back home. My family was still here. And then while I was also living in the States, I was doing a lot of global health projects, the usual, especially once I got my point of care ultrasound training. So I was in East Africa a lot. I did a lot of work in Liberia, some work in Ghana, Uganda, Tanzania. I was designing a national point of care ultrasound training program in Zanzibar. So I was kind of going all up and down that island. That's those 2 months, trying to do a needs assessment of point of care ultrasound needs. And so I was just always in and out of the continent. I'm most happy doing that work. But it's really hard to make an impact when you're just coming for 2 to 3 months. And frankly, I was happier when I was in Africa than when I was in the States. So when I had the opportunity to come home, the challenge is just going for it. And so once I was here, I just decided to stay. I didn't want to go back. And so here I am. And so when I came back home, initially I was, just trying to find my footing. I didn't go to medical school in Nigeria and, all of that. So I really had to establish myself professionally. So I started off thankfully, I actually started off working with a group of critical care physicians who were manning ICUs in private hospitals. And that's how I sort of got back into clinical care in Nigeria, because those skills are really scarce around here. Not a lot of people who are comfortable managing critical care. And it's, at least for us where we train, it was bread and butter. We did a lot of it. And so I started that way. And during the course of that, really got to learn a little bit about the challenges around giving acute care in a setting such as this. And then COVID happened. I had formed a company, Emergency Healthcare Consultants, that was focused on education and training in emergency and critical care. And so myself and a group of ER doctors, there was only about four of us on the ground at the time. Myself, one man who trained in a joint Ghana-Michigan program, and then two doctors who actually trained in South Africa who had come back home. So the four of us banded together and we ended up managing this COVID isolation center, which was the first one in Nigeria. We were running it as as joint medical directors and then managing the critical care patients. And that was just, I think, a pivot point for us as a group because it really began to show our quality as EM doctors. I mean, everyone else was pretty scared to go into the tents. It was the beginning of COVID. Nobody knew anything about what was happening. So a lot of the people that would have traditionally got that role were older and were frankly frightened. And we were young and just like, we have to prove ourselves. So we said, we'll take it. We'll do the job. So we took this job and for 3 months, we managed that isolation center. I'm really proud of it. It was the first one in Lagos during the first wave of the pandemic. And so we were getting referrals from all over the country. And at this time, there wasn't anything known about it. We didn't even know about dexamethasone yet. We managed a lot of patients and really got to show what emergency medicine can do. And we converted a lot of our junior doctors because so many of them ended up going into emergency medicine after that. I think it was the first time they'd seen senior doctors like that, the ER model, where we're with them and we're managing patients with them and we're just kind of there in the trenches. And that's not really the consultant way in Nigeria. They just kind of, in Nigeria, the consultant shows up, kind of waves, gives their blessing and leaves. And so to kind of have the senior doctor there beside you at 4 a.m. battling the vents was was new for many of them, and I think it really won a lot of people over. So we did that, and that was kind of how I sort of started to ease my way into emergency medicine in the country. It was really through that experience. I got to meet a lot of people working in those two jobs and kind of trying to explain what I was about and what I was doing. Because when I arrived, the specialty didn't exist. It became recognized nationally the following year. And that has always been the challenge for me all the times I was traveling home. Just how am I going to do this with a specialty that isn't even recognized in Nigeria? I'll end up becoming an internist or a surgeon. And so it was very fortuitous for me that after I arrived, the National College invited me to be, at the time, a consultant on the faculty, and shortly thereafter accredited the specialty in Nigeria. So that was a big turning point for us.
Yeah, I can imagine. And also, it's not that there was much good about COVID, but it did offer you a chance to showcase your skills in such a nice way.
Yeah.
You mentioned that in 2019, emergency medicine didn't really exist at all, or throughout the times you were traveling back and forth. And you're obviously filling a gap that was there. What was in that gap before emergency medicine? If somebody had a need for acute care, would they be just rock up at a hospital and then the admitting team would see, or a very junior doctor would try and make a decision about which senior you would need to see or which specialist, etc.?
It's actually still that way in the majority of the country. I would say 99% of the country still runs that way. Remember that there's only 2 or 3 specialist trained EPs in country, and our residencies have just started, and Nigeria hasn't actually graduated yet a native trained EP. So most of the emergency departments in country are still run in a variety of ways. Unfortunately, one of the things we're battling here is the equivocation of emergency medicine with life support courses, which are very, very useful, but certainly being an EP is not BLS and ACLS, and that's just sort of gospel we're trying to preach. So even though we've been recognized, one of the things that we are trying to educate people about is, what does an EP do? What does an emergency physician offer you that is different from what is on the ground already? And who can call themselves an emergency physician? Because prior to residency trained doctors arriving on ground, many people were calling themselves emergency physicians by virtue of primarily working in the ER or running life support courses. And so that's kind of a perception we're trying to change. So what currently happens in most places now is, unfortunately, that the most junior doctor is placed in the ER. And the undergraduate curriculum in Nigeria doesn't really have, in most medical schools, a few have started to incorporate it, like the Lagos University Teaching Hospital, but most places don't have an undergraduate curriculum that includes emergency care and emergency medicine. So unfortunately, these very inexperienced young doctors are placed in the area of the hospital where you have the sickest patients. And all of this is really contributing to some of the morbidity and mortality we see in Nigeria around outcomes for emergency care. We're not even talking about complex things. We're just talking about the ECC, just basic emergency care, oxygen, basic airway management outside of intubation, basic management of shock, identification of patients who are ill, a coherent and organized triage system. Like these are the things we're even trying to get most places to incorporate, and to have a dedicated senior physician who has some level of training to oversee this department. So that's what's happening right now in most places. And then it's still very sort of backward in Nigeria to an extent. The ER, emergency care space, is still very fragmented. So in a lot of the teaching hospitals, there's the medical ER, the surgical ER, the ONG ER, the PEDS ER, the ERs everywhere. So they'll tell you, we have 500 beds, and it's like 6 ERs, which is not unexpected when you think about the fact that it wasn't owned by a specialty. And so it's the way it was in the early days of EM in America. It's the same way it was in the UK. Specialists pick their patients out of the pool and kind of move off. And I think naturally it evolves as emergency physicians come to the fore. First of all, the ER will coalesce into one emergency department because we are not thinking of things in all these different ways. An emergency is an emergency. And then also it will just change in terms of how we structure things. But for now, most ERs are still run by non-EPs and don't have emergency care residencies at the teaching hospital. So it's only about 3 or 4 of the centers that are actually beginning to change that. We have accredited 10 sites, and I think 5 have started training. So we're still very much in the nascency of this specialty trying to build up. So we're still in the old days in Nigeria. We haven't turned the corner yet in most places.
Do you see that as an opportunity? A lot of places where there are very established emergency care systems and protocols that often don't actually exist in writing, but it's the way that things have always been done, etc. It's very difficult to change a direction or to change a perhaps non-existent protocol because that's the way that people have always done something. But in Nigeria, if you are stepping into a new realm and sort of trying to change things that didn't exist in a certain way before, do you see that as an opportunity where it actually might be easier to set up something EM orientated from the beginning?
Certainly, I mean, don't get me wrong, people are entrenched here, and there's already agendas around because there's a lot of people that are doing well from these life support courses. And in full disclosure, emergency healthcare consultant runs BLS and ACLS as well, but I try to explain that please do not come here and take these courses and think I've made you an EP. I advise you to go and get yourself some real training. These are things that this is not emergency medicine. This is just so you have some kind of organized thinking when you see a code. But outside of that, there's definitely, it's been really tough in some places to really get people to think about things anew. I think for us, the reason why we have been able to make as much headway as we have made was frankly the recognition by the National College. Before I arrived in Nigeria, so many EPs had come from the diaspora attempting to do the work, and it just wasn't going anywhere because there was no way to argue this with the backing of any kind of authority. Once the faculty, the National Postgraduate Medical College of Nigeria, recognized the specialty and began to define residency training and who can be an EP, the argument completely changed because now we were speaking with the authority of the accrediting body for the country and not as solo practitioners coming from the diaspora. And for me, that I think has been the turning point of our specialty because we are still struggling in the House of Emergency Medicine in Nigeria, we are still outnumbered. There are less EPs at the Faculty of Emergency Medicine than emergency physicians. But the National College just gave us this platform that has made it so easy to make our arguments. And even in places where they are resistant, as more hospitals begin to accredit residencies, the tidal wave is forcing people to sit up because they don't want to be left behind. And then we have a faculty that was just stellar. When I joined, I was the youngest person. I am the least in seniority. So I had to be very careful. But I have a chair, secretary. The board members have been so supportive of this specialty. And they read the memo. They understand that we are here to shepherd you guys to maturity and then step back. So at every point in decision making, they are coming to us as the EPs in the house. Is this okay? This is what we want to plan to do. Do you think it's appropriate? And just that has been what has given us the weight that we need to fight the battle. Otherwise, it's been really entrenched. And a lot of people have been trying for years before I arrived back in Nigeria, trying to make headway with emergency medicine. It just wasn't going anywhere.
And that was due to the entrenchment and the way people always did things, that it was just shifting back to the norm.
Yes, absolutely. Absolutely. So now it's different. Our next battle, I think, is establishing the residencies and ensuring our first cohort of residents are competent. So we're all stretched really thin as we try to cover some of these sites that don't have an EP in-house. And then I think the other part for us is that, we don't have departments of emergency medicine. All of the training programs are in the teaching hospitals. There are no academic departments of emergency medicine. So there's no undergraduate EM curriculum. There is no opportunity to form our academic departments, which means we're not involved in grand round research, training on a formal basis at much of the teaching hospitals. And so that's the second battle we're trying to fight now. Now that we've been recognized at the postgraduate level, can we get recognized in the undergraduate level as well, so that we can actually begin to have our own departments of emergency medicine? I mean, in 4 years, 20 residents are going to graduate. They need to find jobs. They need to get into the cadres of clinicians. They need to be recognized as lecturers, senior lecturers. If we don't get into the departments of EM and get into the colleges of medicine, that is not going to happen.
And also that'll just allow influence to be had on young training doctors to think like an emergency physician, which is I think is a good way to think. How are you going about adapting? So a lot of emergency medicine, the standards or the teaching is geared towards high income countries, and the management of certain conditions, both in view of time and investigations and ultimately management, is geared towards high income settings. How are you going about teaching emergency medicine in a Nigerian setting with the realistic resources that you experience on a daily basis, which is obviously very different in urban and rural and all sorts of variables?
Yeah. No, I'm so happy you recognize that it's quite variable even within country. But for me, this is the perpetual challenge. I haven't resolved it. It's actually my research interest. So we're studying sepsis now. I'll talk a little bit more about that in a bit. But yes, it's been a source of great frustration. But for me also, the thing I find very exciting, because it means that there isn't very much that's out there. And so you have the opportunity to sort of create the evidence-based guidelines that work in this environment. So Nigeria is very poor. Forget about what you're seeing on Nollywood and Burna Boy. Most Nigerians are very, very poor. And affording emergency care, which is a resource-intensive and very expensive experience, is really out of the reach of most Nigerians. And yet our specialty works completely on early recognition, early treatment, early diagnosis, and you're doing a lot. And so for me, it has been a complete shift of thinking around what is most important to do, and what is cost effective, what is feasible, and back to the basics, right? And I work in a somewhat resourced environment. I'm working in a private hospital where I have what I need. It's just that in the ER, some of the patients who show up at the door can't afford it. And we certainly cannot continue to give charity care. There's an extent to which I can do that, then an extent to which the hospital management is going to say, come on, you're not Mother Teresa. So we've been trying to balance this, and I think it comes down to the thinking of emergency medicine, always triaging in your brain and shifting those patients around in terms of who's sickest and who needs your attention. The thing that's been the most challenging for me, especially coming out of the States, where we practice very defensively and you just kind of blast the patient and then think about the money later, is really thinking through what do I have to do now and what is going to give me the most bang for my buck, and where is the mythical line where I need to draw it and say, now that you are out of funds, I have done as much as I can, and now we have to reconsider what we're going to do next. The mandate I give the ER staff is stabilize first and worry about the money later. If somebody's croaking in front of you, please, for God's sakes, don't be asking about money. Do what you need to do. Once they're stable, you need to start having those conversations around how we're going to continue and manage them. And it's a very tough line. It's not clean. And a lot of times we've ended up really getting into it, going full board critical care, vent for days. And you're just looking at them like, okay, now I have to defend how I gave them all this treatment, racked up a bill, and they can't pay for it. My management have been very supportive of what we're trying to do around becoming an access hospital for emergency care, but I do try to be sensible about it. It has been difficult. It's been a challenge. And so for me, it's a research question. And that's what led me to the work I'm doing now. We started a sepsis registry. We're trying to develop a local practice guideline. And it's one of many things I want to do. I want to start with sepsis, but we have to go to trauma. We have to go to stroke care. Everything I learned in residency doesn't work in Nigeria. None of my patients make PCI in 90 minutes. None of my strokes are here within an hour for TPA. Nobody. They come days, weeks later when they have tried everything, taken anti-malarials, gone to the local bone setter, then they arrive to you because there's nothing else that they can do. And my public hospitals here, unfortunately, are not a backstop for me. I cannot rely on them all the time because they are also facing a lot of the challenges that we are facing in the private sector around providing care that is presumably free but actually costs a lot with diminished funding and not a lot of resources put to this by the national government. So we're in crisis. In Lagos State, where I live, we have been told, the state has mandated that everybody must sign up for the state health insurance scheme. I think that would give us a little bit of a buffer because insurance is pooled risk. There's going to be a lot of people on it who are well and will never use it and have paid the premiums, which you can then apply to people who are sick who come in. But that's going to take a while to build the sort of pool that would make sense. I mean, when you look at the Netherlands and some of these other countries with state health insurance, it's been going on for decades. They have a lot of money. It's been years of people paying premiums. We're just starting that in Nigeria, so there's not a lot of money that will be in it yet. And we're still battling them on the coverage because it doesn't make sense in some places. So to say that I don't have the answer, money is a problem, so we do what we can. You just try to meld, merge, modify the protocols as best as you can, given what you're seeing. I've definitely learned a whole lot about how to adapt the high income medicine I learned to the environment I'm in now. Some things are just not feasible. You just can't do them here. And that's the truth.
Yeah, it's like you said, the people come days and weeks after presenting with the stroke, and then a lot of the places don't have a CT. So it's not even, they're never going to get a CT, let alone within a few minutes. And then you just have to treat it case by case and try and make the best decision
Yes,
you can.
absolutely. Absolutely. Even you would have to question at 2 weeks after the stroke, what is the value of the CT? Clearly, they're not going to die. They've been hanging on for 2 weeks. So, should even waste whatever resources they have on it at that point? Those are the kind of questions I never had to ask in the US,
If it's still clinically a stroke after 2 weeks, it's probably a stroke.
Yes, exactly. Exactly. So definitely a challenge, but I think that's the research question that's interesting and the place where we can really do some clever work to develop guidelines for our own environment.
To change the topic a bit, please share your experience as a woman being at the forefront of what you're trying to do in Nigeria, establishing emergency medicine. And then if you want to comment on the media coverage, and I might pronounce her name wrong, but Senator Natasha Akpoti Udogan with her sexual harassment claim. And I mean, the article I read about her in The Economist, even before that, she was having to jump through about 10 different hoops every morning, even though she was already a senator trying to speak at the
Yeah.
Senate. So it didn't sound like she was having a very easy time. So, what has your experience been as a woman trying to get something done?
It's been a mixed bag. I think on one hand it's been an advantage, and then on the other hand it's definitely sometimes been a challenge to manage. Um, I think that there was definitely sometimes when the environment was inappropriate. Thankfully, I never was harassed, but certainly you're in rooms where the conversation is not professional. Sometimes there are assumptions made about you, but I think it would have been harder to manage if I had a different personality, which has been a boon and also a curse. I'm extremely outspoken. I'm not a quiet person, and I'm not a restful sort of individual when I'm pissed off. And so that has actually been a lot of a shield for me because people knew that this one has a big mouth and she's really not the kind that will just be quiet and go in the corner. So I think it ended up actually being very helpful to me because inappropriateness was kept at the level of just in conversation. I never felt physically uncomfortable. And I think I made it very clear from the start that that was not tolerated. I think also if you're a good person and you've got your skills and you are just good at what you do, that for me was also amazing. There is no question that she knows what she's doing and she's managing her patient. That was helpful for me. I think sometimes in fields maybe where things are a little bit more theoretical, in emergency medicine there's still a very physical part to our specialty. Doing CPR, putting in a central line, and people are watching this in a place where they don't see a lot of this going, wow, it's really happening. That really helped kill a lot of the doubt in what we were doing, and then to be able to really teach and have people see the progression of mentors and trainees and mentees and trainees and how they are progressing has really helped me. So just like Natasha, I think every professional woman in Nigeria and even all over the world, you're in situations where you're smiling, but inside you're furious. People are saying things that you just are very angry about. When I first arrived, I would attack immediately. With the wisdom of age now, some of them I just let it go. I just smile. I just walk off. Or I use my mail proxy. I do that a lot because where I am now, I have a very supportive management team, and my supervisor, who's the founder of the hospital, is an amazing father figure to me. And so sometimes when I want to say something and I know it's not going to come off the way I want, I just ask him to say it, and he says it on my behalf, and that sometimes goes down better. I play good cop, bad cop a lot. So I actually co-opt my male colleagues a lot when I need to get something done and I'm realizing I'm hitting a barrier. Listen, come, because it's like they need to hear it from a guy. So I will tell them, it's like you have to hear it from a guy. Yeah, guy, talk to them so that they will understand what I'm saying. That has helped me, but it's the benefit of where I am. I think that Natasha's case is, I think, just so infuriating because women are still very demeaned in professional settings. We've made some headway in financial services in Nigeria. A lot of the bank managing directors are now women. But there's always murmuring in the background about how she got to that position and whether that person is capable. For me, nobody who's in power ever gives off their power willingly. So if we think that men are really just going to sit back and open the doors, you're crazy. You have to fight for what you want. Why would they give you what has been traditionally theirs? I think what infuriated me about Natasha's case is that it is the women who are now saying things like she's a liar, she should be sanctioned. we need to make sure that we give the Senate president his chance to rebut accusations. But we are all women in Nigeria knowing what we are facing in the professional setting. And so for us to attack her when she's telling you about that experience and not sort of demonstrate compassion was for me the part that was really exasperating. It's just, how can we be the ones that are actually pulling each other down? Can we not give her the benefit of the doubt and listen to her and support her? Because most women would have been quiet about it. She knew she was going to be blackballed for doing this, and she was going to be a pariah. So whatever happened must have been terrible for her to decide to speak up. And if you can't fathom and think through that, you're really stupid, in my opinion. That's how I feel about it.
Yeah, I like the way you said that you're not afraid to use your male proxies if somebody needs to hear it from a guy.
And then they will come back eventually and say, okay, you were right. I said, yes, I was right. I know, but it seemed like we needed to hear it from a guy. So, man, come and talk to man.
Tell me about well, I'm not actually sure, so this is going to be new information for me, but how much does Nigeria use USAID or rely on any donations for their healthcare system? And how has that been affected by the drawbacks on USAID?
So I don't have the exact figures, but when I was looking at the data, apparently we were like one of the biggest beneficiaries in Africa with Ethiopia. So it has hit us very hard. I think PEPFAR was funding a lot of our malaria HIV programs. Even in my hospital, our TB screening program was USAID funded and they've disappeared. And it was very sudden. Once the cuts were announced, they just disappeared. And so we're all having to rethink how we're going to support those programs. It has definitely hit hard. I think Lagos is an anomaly because so much of healthcare resources in Nigeria are concentrated in Lagos. And so, in typical Nigerian resilient entrepreneurial fashion, people are seeing a business opportunity and trying to fill the gaps. That's possible in Lagos or in a place like Abuja or maybe even Port. But for the majority of the country, when we are talking about a very rural areas or places that are not in the center of what we would consider to be commercial interests or even foreign interests, this is really going to hit hard. A lot of the vaccination programs are dependent on USAID and on foreign funding. A lot of our maternal and child programs were dependent on foreign funding. Our TB prevention programs were dependent on foreign funding. And so it's actually been a big gut to our system. I think it is also going to be a wake-up call. I hope that in Nigerian fashion, realize that this is actually something that has been done for us, but that we should have been planning for. One of the problems I've always had with foreign aid has been that there's never the exit clause. They're never planning for redundancy. So you end up on aid forever, and you just end up having weak systems. Aid just propped it up. And we never had a situation where we had to think about how we were going to manage meager resources. The way that it happened, was it the best? Absolutely not. Who wants to just have it cut off overnight? But certainly I appreciate the fact that this is forcing us to have a reckoning and have some very tough conversations about what we're going to do without it, because we could have just kept going on that path for the next century. And how are you ever going to have a say in your destiny if you're not the one in charge of the money? We can talk all we want about Africa being marginalized and demoralized and bad health outcomes. But if you continue to rely on other countries to fund your health, then their priorities are what are going to be pushed. So a lot of things were not getting attention. We're going to focus on what USAID thinks is important. So surgical services, critical care services, emergency care services, things like that, were not really the things that were being funded from a personal perspective. It was mother and child, it was vaccinations. Those things are very important. Public health programs, very important. But you can't have a universal healthcare system if you don't also strengthen other parts of it. It's impossible. So the agenda and the priorities were set by the donors, and that forced us to toe the line. And then, very importantly, of course, climate change and environmental safety and guide, all those things were coming in. They are important. We didn't cause most of the damage to the environment, but we're going to suffer the most for it. But nevertheless, the way in which it was being implemented speaks to an agenda set by the West and not necessarily an agenda that benefits us as Africans. So it's a lot of pain. But the way I see these things is it's also an opportunity for you to really rethink how you're going to approach this problem and figure out how we're going to do it with what we have. Maybe this will boost our local pharmaceutical industry to start making generics made in Africa. That's what changed India and Bangladesh. Maybe this will prioritize and help local device manufacturers to really sit up. When you have aid, none of that happens. Let's see what we can do now that we know the money is gone.
And do you think the politicians will now maybe reprioritize healthcare that they know that they are not going to get for free?
Let us see. You know, the politicians don't access care in the country, they fly to France. So let us see what will happen. I love some of the things that our Minister of Health, the Senior Minister of Health, is doing. A lot of the folks who were hired through those programs were rehired under Nigerian agencies. They may not get the same remuneration packages. He's worked with Gavi, so he's a very sensible fellow who understands some of the ideas behind policy and healthcare system strengthening. It's certainly motivating us in the private sector to sit up and do more. And that tidal wave in health was already happening around the eventual decline of the small mom and pop shop and consolidation of health systems with a focus on quality and systems. So I think in a few years it's really going to change. What the politicians are going to do, I'm not sure, but also I think historically we have tended to think politics is dirty and we're not going to advocate. One of the things I've learned since I've come home is you need to start talking to the politicians. Whether or not you think that they are corrupt, politicians only know what they are hearing. So if you want your case to be heard, you need to dust off your shoes and your hat, go out and break it to them in a language they understand so that they can prioritize your issues. So we just have to do more around advocacy, which has typically been something that a lot of us are just like, oh, I don't want to deal with them. You have to deal with them if you want to improve this country. You have to deal with them. So we'll see. You know, it's early days.
Like you said, they are the ones with the budgets and they are the ones with the power to make decisions. While they make a lot of silly decisions sometimes, maybe they don't have all the perspective that you have. So it's important to talk in a way that they can understand and listen.
Yeah, and it's all about money, right? You can't go to a politician and be arguing that this is humanitarian and it will save lives. They don't care. Neither does your funder, or your venture capitalist, or your investor. You need to show how this is going to save them money, make them money, how this is going to help them look good. And once you get that and you can make that argument, speak to their interests, I think you get much further. Sometimes the problem with health is we go there with our bleeding hearts. Help us, this is the right thing to do. Who cares about the right thing to do? Even Bill Gates doesn't care about the right thing to do. He cares about impact and where his money is going to be spent. And that's how you have to talk to politicians sometimes. And I think we just have to understand that and couch the message in those terms.
Well said. If you had a magic wand and you could wish for one thing to materialize overnight within healthcare in Nigeria, what would it be?
Comprehensive universal healthcare coverage.
So the state health insurance that you were talking about that actually
If it
worked.
actually worked, where you didn't have to worry about how stuff was going to be paid for, just go. That would be a game changer for us in emergency medicine and critical care.
And so you said so South Africa has also passed a bill for the national health insurance, but it hasn't been implemented yet, and it's going to be implemented in stages, I think, over the next whenever it happens. What is the state of that in Nigeria at the moment, and what is the current situation? Do you have medical aids that cover your costs in private, and then the public hospitals are all completely free?
Yeah, so the way it works in Nigeria, and don't quote me, is that there's a national mandate for every state to establish a health insurance scheme. So kind of like Medicaid, Medicaid per state, if you wanted to have like something you could compare it to. And different states are at different phases of implementing that. So I would say that Lagos is the most ahead. There's a National Health Insurance Act that mandates that every state must establish a state health insurance scheme. And then the coverage and sort of what is under that scheme is being decided by the National Health Insurance Act. And my understanding is I think that there are allocations for different states and different categories of treatment. What we're all trying to understand is how to get states who haven't started to start their health insurance schemes, how to advocate with the agencies to bring the coverage and the premiums up to a level that actually provide care that is reasonable. If we have runaway inflation right now, the value of the naira is depreciated. We need the coverage to actually be reasonable given the current inflation and cost of living. Don't give us 5,000 if it costs on average 300,000 to access emergency care and get comprehensive coverage. So that's one thing. I think we're trying to understand how it's going to strengthen areas that have typically been neglected, like surgical care, like critical care, like emergency care. So those are some of the things that are happening. And then there's a plethora of private health insurance also that is in the market. Though the current guideline in Lagos is that irrespective of you carrying private, you must still sign up for the public health insurance scheme. But they've not actually really started to enforce that. But that's the edict that we got this year. So I think we're trying to drive people towards it to build a pool. On the private health insurance side, of course, your coverage is better when you're on the high value plans. But I think health insurance in Nigeria is still very much in its nascency. And a lot of the health insurance, a lot of the HMOs are actually bankrupt. They really can't cover everything. So you also have to be careful who you're doing business with. But I think we haven't yet really begun to focus on health outcomes. So the HMOs are seen in a very much like a negotiating price mood. They haven't yet pivoted to rewarding you for good care. I don't know if you understand what I mean. They're still paying you for treating your patients who come in with sepsis, but they're not yet rewarding you when you have a hospital that actually implements a sepsis bundle that's evidence-based. They're still, rewarding you when you treat your patients and give them antimalarials. They're not yet rewarding you when you make sure that you're following WHO guidelines for ensuring that there is a test before treatment. They're not driving adoption of quality care yet. And that's really where we need to get to. Not just paying for care, but actually forcing the health industry to begin to adopt a stance where we are following evidence-based guidelines and then you're rewarding providers for doing that. So that's where we are.
And obviously, if there's a financial incentive to follow evidence-based guidelines and to stay up to date with current practice, then people will do it. There's not much more incentive than that.
All the time.
To finish off, what is next for emergency medicine in Nigeria and what work are you currently doing?
Oh my God, so much. So at the faculty, yes, I'm a board member. So this year we're having our first part one exam. I'm the chair of that. I'm very nervous. So our first group of junior residents are going to graduate to senior residency. So we're planning for that. I'm trying to rally all of our resources, figure out the examiners and our questions and all of that. So that's happening. We also started the Association of Emergency Medicine Healthcare Professionals, which I mentioned in Botswana. It's our Nigerian answer to MSAS or ASEP, kind of a professional organization. So we're just trying to rally around an organization that we can use as a vehicle for conferences and for sort of like organizing and coalescing ourselves. So that's really exciting. And of course, the president's trying to hand it off to someone else and being blocked. Very much so. I'm still trying to build my company. I mean, I'm really interested in medical education and simulation. So really fascinated by what's happening in, VR and AI and how we can use that as a mode to sort of buttress education in resource constrained settings. Somehow use that to sort of begin to create a curriculum and a guideline that makes sure essential skills are acquired. So those are some of the things I'm thinking through. I'm writing papers for my research. We're analyzing data. We've written our first qualitative paper. I'm working through the reviewer comments, trying to figure out my registry. And I'm doing a lot. I'm doing a lot. And I'm a mother and a wife. So I'm doing a lot.
And your mother, Eva.
Yes, I am. I'm running my hospital system, Arjalad. So there's a lot to do, but I'm happy. I'm happy that I'm in a position to do that. And I feel like I came home at the right time.
And obviously, if there'll always be a lot to do in an emergency medicine health system that's so young. There'll be a lot to do for the next 200 years.
Yes, indeed.
But it's a nice position to be in if you can do some
Yes,
of
the
that stuff.
reward for work is more work.
Well, thank you so much for joining me on the podcast. I really enjoyed that discussion, and I'm sure our listeners will too.
Thank you, Dan. I really had a good time talking. Thanks for having me on.
And that's all for this episode. To summarize, we started talking about the state of Nigerian emergency medicine. We spoke about Dr Fasina-Ayoola's brand of feminism. We touched on USAID and how its withdrawal might actually be a long-term blessing if we react appropriately to it. And we ended off with some general wisdom from somebody who clearly knows how to move mountains, about how to talk to politicians and how to get things done. And that's about it. Be sure to review and subscribe to our podcast on all of your main platforms and send this to a friend or a colleague who might find it interesting. If you want to get in touch, find me on LinkedIn or email me at dan@badem.co.za. Please follow us on Instagram and Facebook at Brave African Discussions and X or Blue Sky as Bad EM. Thanks for listening. See you next month. Bye bye.